robots here, something later on, like this.
Everybody. There's a
we can hear you, Vittorio, but people who have not muted themselves.
Yeah.
Paolo,
yeah, I can hear you. Hi, everybody. I can hear you, Vittorio.
Okay, thank you. Paolo, can you? Okay, now it's okay. I share the screen. So, okay, can you see the screen?
Yes.
So, okay, thank you very much. It's an honor to me to be here. It's not easy to to talk after Professor Bruno is a great expert of vertebral artery, and but I will do my best. So I will give a more the radiological point of view concerning the anatomy of the vertebral artery. So I have no disclosure for this talk. So as we saw before, vertebral artery is the first and main collateral branch of the subclavian artery, and normally enters the transverse canal at the C6 transverse foramen. And then it contours the atlas and gives its largest tributary, that's the posterior inferior cerebellar artery, the pica artery, after piercing the occipital membrane. And then it joins the other vertebral at the vertebrovascular junction and to form the basilar artery. Going in a little bit deeper into the segmentation, there has been historically several proposals of segmentation of the vertebral artery, and we can identify this segmentation as the most used today. We identify 4 segments of the vertebral artery, the so-called V1 or preforaminal segment. And this is origin, it got from the origin to the transverse foramens of and then C6. Then we have the V2 or foraminal segment that goes from the transverse foramen of C6 to the transverse foramen of C2. Then we have the V3 segment that goes from the C2, and then it loops and to the and continues to the C1 and pierce the dura at this level. And then we have the V4 or intracranial or intradural segment that goes after piercing the dura and to the confluence on the medulla to form the basilar artery. But to understand a little bit more the anatomy of vertebral artery, we can go a little bit deeper into the embryology. It will help us to understand the variation that we see when we perform angio-CT studies or angiography studies. So in the early fetal life, we have some segmental horizontal branches that extend from the cervical to the sacral region, and they vascularize the developing somites. And then all the transverse arteries are connected by pair longitudinal channels that we can identify as the ventral aorta and the dorsal aorta. And then more longitudinal channel will follow in the developing fetus. So the dorsal and the ventral aorta are connected by 7 pairs of aortic arches, and the 7 segmental artery from the lower end of the vertebral artery. And then we'll send a branch to the forelimb bud and to form the subclavian artery. On the left side, the 7 dorsal intersegmental artery persists, and they will form the entire proximal left subclavian artery. On the right, the 7 dorsal intersegmental artery will form the distal third of the proximal right subclavian artery. And then the proximal and mid-zone of the proximal right subclavian artery are formed by the right 4th aortic arch and the right dorsal aortic root. So the point is that the anomalous origin arises from aberrant anastomosis at any time and during the embryonic development of the arch. And that the time and location of these anastomosis will determine the ultimate adult anomalous origin. So in an embryological point of view, the segmentation is a little bit different. We can identify 3 segments. We have the first segment or proximal segment that correspond to a persistent primitive intersegmental artery, generally the sixth. Then we have an intermediate portion, consists of a series of longitudinal anastomosis connection established between the first 5 cervical intersegmental arteries. And then we have the distal portion that's derived from the proatlantal artery and from the terminal vertebral artery. So in the each level into the cervical level is vascularized by these horizontal arteries that will vascularize the vertebrae, the cervical spine, the occipital bone, and their associated nerve, muscular and vascular cutaneous elements. And these vessels are united by some longitudinal arteries. And we have the vertebral artery, but we have other vertical axes that will be formed during fetal life. So we'll have the ascending cervical, the deep cervical artery, the occipital artery, the ascending pharyngeal, and the supreme intercostal artery. And so any vertebral artery dysfunction during the congenital, that's congenital or acquired, is most likely to be taken over by this transverse segmental anastomosis of the Abramowitchian vessels. And so the variation become very understandable and predictable. And this is a representation scheme. So we have these segmental arteries, and then we have the development of these intersegmental vertical arteries. We have some kind of regression, and then we have the formation of the adult form of the vessel. And so we can explain some different configuration that we can find in our studies. So we can have, for example, the direct origin of the vertebral artery from the aortic arch. And it can be explained by a lack of regression of the sixth segmental arteries and the permanent connection with the aortic arch. And it can be identified on the angioscan and angio-CT study. It can be alone or associated with other more complex anomalies like this bovine trunk, or even more complex one, as in this case where we have an independent origin of the whole supraortic trunks. Or we can have duplications, a tree duplication of the origin of the vertebral artery, as in this case. And here again, it can be explained by an embryological point of view by a lack of regression of the two intersegmental pairs, and so the persistent in adult life. Or this is another case of a true duplication of the origin of the left vertebral artery. And so it's an injection from the part originating from the subclavian artery, and then a retrograde opacification of the duplication and the aortic arch below. It can have some clinical implication. There was a patient referred for a suspicion of vertebral artery dissection, but the injection of the brachiocephalic trunk showed no vertebral artery and no reconstruction of the vertebral artery was seen from the deep or the ascending cervical injection. But injecting on the left side, the left vertebral artery allowed to visualize the right one. And so the right vertebral artery was found, finally injecting the supreme intercostal artery that gave origin to the vertebral artery. Or again, the right intercostal artery can originate from the vertebral artery in an inverse manner. We can have a far lateral origin of the vertebral artery from the aortic arch, or again, we can find this kind of anomalous origin from the right common carotid artery, and this is a configuration that's more frequent in the right aberrant subclavian aortic arch configuration. We can have some duplication, again, that can be explained embryologically, or we can have a different configuration where a so-called vertebral artery origin distal from the inferior thyroid artery. It can happen on the left side, or it can happen on the right side, where we can see the inferior thyroid and the right vertebral artery. And in this case, we can also see a different point of entry in the interforaminal canal. And maybe we can think that embryologically we are talking about a different vessel. So, for example, again, we can see a so-called vertebral artery that entering the neuroforamen at C5. But actually, from an embryological point of view, we see a deep cervical artery that reconstitutes the vertebral artery via muscular transverse anastomosis. And the original, the fact that the vertebral artery originates distal to the inferior thyroid artery confirms that the proximal vessel is really the deep cervical artery. And it can have clinical implication. We can see a post-op CT scan after a cervical fusion, and we can see the left CC screw within the vertebral foramen. But during surgery, there was no indication of vertebral injury or any postoperative change. And when we see the angio study, we see that the so-called vertebral artery has an extra osseous course entering the foramen at C3 level. At this level, very far above from the CC screw. And embryological, this so-called extraosseous vertebral artery is not the same as a true vertebral artery because it's a tip cervical artery that reconstitutes the true vertebral artery. And the true vertebral artery below the foramen is hypoplastic. So we had the regression at this level, and so the deep cervical artery take over the true vertebral artery. And this is what we see. But then we can have common origin, for example, in this case, with the common origin of the vertebral artery and the deep cervical artery. And we can see, again, the level of entry at C5. Or we can have a different level of entry at C4, for example. And in this case, usually the proximal vessel is the ascending cervical artery from an embryological point of view. And it can have clinical implication, as in this case, we have a vertebral artery entering in C4, and is highly more mobile from a normal vertebral artery. We didn't consider that when we decided to treat these dissecting arteries with a flow diverter stent. And the patient arrived two months after the treatment with some minor stroke, and we can see the CT scan after showed some metal parts inside the brain that weren't present 2 months before. And looking at the stent was completely broken, and one of the possible causes was the increased vascular motility of the vascular anomaly. And as we saw before, is possible to have an asymmetry of the two vertebral artery, and more than half of the time the left is larger. And to understand if we have a true hypoplastic vessel, is always useful to look at the size of the foramen, because embryologically the foramen follow the vessel. So as we saw before, there are several anastomoses that can be identified between the other longitudinal vessels, and the anastomotic channel are formed by transverse segmental arteries at the different level. And the anastomic artery varies depending on the level. And this is a beautiful picture. It was an injection of a vertebral artery in an occlusion method that allowed to identify all these possible connections: the arteriospinal artery in red, the radiculomedullary artery in white, or the epidural arcade in the yellow, or the odontoid arcade in purple, the muscular branches, or the neuromeningeal trunk and the pharyngeal trunk of the ascending pharyngeal artery, and again the occipital artery, the deep cervical artery in pink, and the ascending cervical artery. This is a case of a vertebral origin dissection where the there are the ascending cervical arteries allowed to reconstitute the vertebral artery, and also took over the territory of the deep cervical territory that was hypoplastic. Another case with the injection of the ascending cervical artery that had anastomosis and reconstituted a dissected vertebral artery, and also allowed to keep the vascularization of the spinal cord. As we saw, there are anastomosis with the occipital artery, and we can have the so-called type 2 proatlantal artery, that the second intersegmental artery, and it can persist during the adult life, even if it's rare. And but usually it regresses, and but it's always present as a potential anastomosis at this level. So from a neurointerventional point of view, we don't use lipid embolic agent in the proximal part of the occipital artery because it can open this anastomosis, and then from an injection from the occipital artery, we can find ourselves with a vertebral stroke due to the opening of this anastomosis. We can have the type 2 proatlantal artery that can persist very, very rarely in the adult life, but usually regresses. It's very important to know the anastomosis with the ascending pharyngeal, especially when we are dealing with this kind of lesion. For example, for preoperative embolization, we never use liquid embolic agent in these cases, because we can see this injection in the ascending pharyngeal allow the opacification of the two vertebral arteries through the odontoid arcade. And this is another case showing the same configuration. So in these cases, we prefer to do proximal embolization to avoid to open this kind of dangerous, so-called dangerous anastomosis. Then it's important, considering the anatomy of the vertebral artery, it's important to consider the vascular supply to the spinal cord. And we know that supply the cervical anterior spinal artery by multiple radiculomedullary arteries. From an embryological point of view, we know that even the arteriospinal artery is formed from a midline fusion of longitudinal anastomosis, and the radiculomedullary artery that supply at every embryological level partially regress in adult life. So these are the main apport for the vascularization of the cervical spinal cord. So it's important to look for them. Sometimes the continuity of the anterior spinal artery is assured by homolateral apport to the cord, and sometimes from bilateral apport to the spinal cord. So coming to the conclusion, the two vertebral arteries then end up and form the basilar artery. And the main collateral branch in the V4, so intradural segment, is the pica artery. And even the basilar artery is formed from a fusion of longitudinal neural system, and it can be explained from an embryological point of view as an extension of the segmental arrangement found in the spinal cord. The variation that are very common at the level of the pica can be explained by these different taking over during the fetal life, and we can find ourselves in situation like this with an extra dural origin of the pica. But if we look very carefully, we can see a perforator at the level of the normal origin of the pica. So the cortical part will be vascularized by the extradural, but the spinal cord, the perforator, will be taken over by this perforator. So it can allow us, for example, to sacrifice, if it is needed, this pica without potential spinal cord damage. We can have duplicated pica, as in this case, where we have the two origins, one origin from an extradural and one origin from the intradural segment, and the extradural will take in charge the vascularization of the cerebellar hemisphere, while the intradural component supply the medullary and vermian segment. And again, in the extreme spectrum of the embryological variation, we can have also the occipital origin of the pica from the occipital origin of the pica. From an inner point of view, we can sacrifice the pica if we have to, if we have a low origin, if we check very carefully with our 3D acquisition the absence of perforator, and if the ICA has a good caliber. So as a take-home message, I will always love to say what one of our masters said: the anatomy is the cheapest way to be safe. And I thank you for your attention.
Okay, thank you, Vittorio. It was a really nice and comprehensive overview of the anatomy of the vertebral artery, really in details. So thanks a lot. Can you guys hear me?
Yeah, we hear you well.